Hello, I'm Jane Heyhoe, and this is my colleague Caroline Reynolds. We're here today to talk about our work in developing a safety netting intervention, which we are looking forward to actually showing you a draft of the prototype that we've created working with patients and health professionals and primary care stakeholders. So a bit of the background, which I know that we've already covered, so I'm not going to dwell too much on this here. As Richard mentioned in his talk earlier, there is some work out there that is showing that, we have a problem with patients, delayed diagnosis. But what we've kind of found in some of the research is that cancer sometimes it's telling us that there's been missed opportunities in primary care, and we know this by some of findings of that patients have actually been diagnosed in emergency care, and it's been found that some of those patients have had 3 or more consultations beforehand before they've actually presented in primary care and been diagnosed. We know that diagnosis is a really complex procedure, and I don't think anybody here is arguing with that. Often, as well, as Richard again said earlier, diagnosis isn't simple. Often patients don't present with red flag symptoms. Patients often present with vague symptoms over time. There's growing evidence, however, that one of the ways that we could tackle delay is to involve patients much more. And recently, over the last few years, there's been much more kind of literature looking at how patients could play a role in helping to achieve an earlier diagnosis. And some of this work has looked at their role in safety netting. So we have been interested in kind of looking at that particular area. And what we've particularly focused on is the area where patients have presented to primary care with symptoms, but they're not at the stage where there's enough there to refer them. And there might be patients that, actually need to have something that will encourage them to represent back in a timely manner so that a diagnosis can be made earlier. So just a little bit about who we are and our experience in this field. I myself actually completed a PhD that focused on diagnosis, and particularly kind of decision making from the health professional side. My colleague here, Caroline.
So my clinical background is actually in the operating theatres, so not primary care, but I now... Don't like microphones. I now support a number of projects that are looking at involving patients in patient safety. So how can we get patients more involved in things?
Okay, we work at the Bradford Institute for Health Research, and we recently became the Yorkshire and Humber Patient Safety Translational Research Centre. We're only one of 3 centres nationally to be awarded this. We particularly, as you can see, just to give you some background of who we are, who we collaborate with, and our vision there. And this particular work falls in, we have research themes, which you can see there, the safe use of medicines, digital innovations and workforce engagement. We're working into the patient involvement in patient safety that is particularly looking at work that is working with patients as partners to make health care safer. So, what we did when we began to look at this is we wanted to kind of review the literature and see kind of where we were basically with where patients were being involved in helping to diagnose cancer in primary care. The aims there were to identify interventions that involve patients and also to establish key components for engaging patients in diagnosis after initial presentations. Our findings were that there were no interventions that specifically involved patients. But we found 16 articles that provided suggestions of components that were important for involving patients, just so that we could kind of again gain what the knowledge was in this area and try and learn a little bit about the hypothesized mechanisms of what would be needed to engage patients. I'm not going to go into this here, it's a very busy slide, but just to show some of the work that we've done here, we produced a logic model where we looked at the problems, potential strategies, of which safety netting is one of them, what the potential moderators might be, and what the outcomes might be. So after we had done this, we set about to co-design a novel intervention for promoting greater involvement of patients. And just to give you a little bit of background about the work that we've done, mainly qualitative work, first of all. We wanted to consider what the important components were for patient involvement, and we did that by interviewing stakeholders. It's a small-scale study, but interviewing kind of healthcare professionals, GPs, nurse practitioners and patients. And we also wanted to explore kind of potential strategies and what they might think of these, so that we could kind of move forward with what any kind of intervention might entail. So we asked the stakeholders their thoughts on 3 potential strategies. Those were kind of a framework for discussing within the consultation, you know, what the patient should look out for, when they should come back. There was also, the second strategy was backing up the conversation with some kind of written information that the patient could take away with them, which again would tell them what symptoms they needed to look out for, had symptoms changed, had they persisted, had they got worse, and again, what they should do about that. We also explored a third strategy, which was using some kind of prompt. So that might have been a text message or a telephone call, where again the patient was asked to review the symptoms, and again it would give them some information about what to do after they had reviewed that. We also explored our findings by taking what we'd found to a dissemination workshops. And what we found there really was that what was particularly kind of liked was some kind of framework around a discussion and some written information, but that a strategy that used some kind of prompt would perhaps need to be thought about a little bit more. That, you know, in an ideal world, to have all 3 together would be great, but that, you know, there would be a lot more considerations to think about with using a prompt. So what we did is we took these findings and we then entered a co-design phase, and we worked with some colleagues in Sheffield who are experts in co-developing interventions. And we wanted to here explore how safety netting would be implemented in practice, whether it would be acceptable to stakeholders, whether it would be feasible. And we did this by holding stakeholder workshops to, first of all, produce an intervention prototype. And then we took the prototype to focus groups, which involved patients and primary care practices, which helped us to refine the tool. So I'm just going to now move over here. I'm just let Caroline take over here and just show you.
So I'm just going to run through the intervention as it is at the moment. As Jane says, we've worked with GPs, we've worked with patients to develop this, but this is our initial prototype. There's still, I'm sure there are still refinements, still things to be changed, altered, tweaked. But I'm going to run through that now. And then what we'd like to do is invite any comments, feedback, any questions about the particular intervention, please. Please be gentle. So, as we say, it's those consultations where the patients come with certain symptoms, they may be vague ones, they don't meet the criteria for being referred on a 2-week wait, but there are symptoms that we're concerned about, we want to make sure that we're keeping an eye on those symptoms. We want those patients to come back to us if they're persisting or they're getting worse. We don't want to lose those patients. We don't want them to go away. And as was discussed earlier, there might be one message, but different people can take different things from those same words. So we don't want people to go away reassured and not to come back. We want to be keeping an eye on those symptoms. So this is where the plan would come in. There's always acronyms, aren't there, for things. So the Shared Safety Net Action Plan, or SNAP, might be used. And I think it was very clear when we talked to people that, you know, as GPs, you are having those discussions with patients. You are saying, you know, I want to keep an eye on those symptoms, come back if they don't get better. But sometimes it's not maybe as formalised as we're suggesting it could be. So we're talking about making a plan so it's patients have something physical to go away with. They have a piece of paper with those symptoms that we want them to keep on monitoring, and also specific time frames of, well, if it's not resolving, this is when I want you to come back. I know some GPs do give specific time frames, but equally sometimes people say, if it doesn't get better, come back. But sometimes patients are not always sure, well, what time frame is that? And it's easy to forget things when you've got busy lives as well. You forget how long it's been sometimes since you've been, and actually it can be much longer than you thought it was. So this would be something physical that the patient could take away and refer back to. So at the moment, we're very old-fashioned, aren't we? We've got a paper copy, and then we've got stickers that we've put on the paper copy. This is very much for us to, as we've been developing it, for us to show people. But I'm sure going forward, there are lots of, everything's going much more towards technology. So I'm sure that this would potentially be something that could be embedded in systems and potentially pre-populate a lot of this as well, because we don't want this to add to that consultation and add longer. You know, it's 10 minutes as it is to talk to people, examine them, do the documentation. So the template on the left is where the patient's name would be, the GP, when they saw that, when they were seen, with some explanation at the top to say that things aren't clear at the moment, but we're wanting to keep an eye on the symptoms. And then the GP would add the particular things onto this template from the right that they want the patient to monitor. So these are just examples on the right hand side. Obviously there would be many more things that potentially you might want the patient to be keeping an eye on. And also to put a timescale on there of when you want the patient to come back if it's not resolved by. So if it's not got better. And obviously different things would have different time frames, and that would be very much down to clinical judgment. Some things you might want to resolve in a week, some things may take a bit longer. So these would be put on the plan with timescales, and that'd be something that the patient could take away with them to refer back to. Because if you're anything like me, once you've left the surgery, somebody asks you what they've said, I can't remember most of it. So the record would also be in the practice. So if it was on the system, it would be there, which we felt was important, because although you may be returning, you may not be returning to the same GP that you saw earlier. Next time you present, it might be to another GP, so the plan's already there. So you might not have it with you, but it's there in the practice, so they know why you're coming back. They know that it's been decided for you to come back, say, in 2 weeks if that's not resolved. So the idea would be that the patient has this to refer back to. They look at it and think, yep, actually, it's been a couple of weeks. Have my symptoms gone away? Have they not? Do I need to go back and see them? And on the plan, it would say what to do. So you call back to make an appointment. And it's also important, we felt, to put on that also to get in touch if something's just not right. So although we may say your symptoms need to resolve in 2 weeks, or if they get worse to come back, but actually something else might change. So do come back if something doesn't feel right, if you feel that there's a problem, come back sooner. And as Jane discussed, there was also the potential for a prompt. So that would be at this point. So there could be the potential for a prompt to be sent to the patient, again at a time to be decided by the clinician, with something very general to say, you saw Dr. X on the 10th of October, please have a look at your plan, review your symptoms, do you need to come back to us? If so, call this number. So just as an extra prompt for the patient. But that was something that, although we discussed in the workshops, and we discussed when we went to different practices, how that would work in different practices might be different, and some practices felt that that wasn't necessarily something that they were able to do. So that is the overall plan. So what would we hope the impact to be? Well, we're hoping that we're trying to engage the patient more, to move to a more active involvement, so monitoring their symptoms, knowing what the timeframes are, supporting reattendance if necessary. So obviously there may be, hopefully, lots of people looking at the plan and thinking, actually, I don't need to go back, so I won't make an appointment. But if it's needed, that we're getting people back, and that we're hoping that when they're coming back, that we're cutting down that time on getting to a diagnosis, whether that be cancer or whether that be another condition that they're diagnosed with, but getting to that diagnosis earlier. And hopefully if we did that, that may increase cancer survival rates if we're getting people to a diagnosis quicker. So I'll just leave that up now, so if anybody has any questions, comments.